So what I'm going to be speaking to you today about is research that has evolved on the attention deficit hyperactivity disorder from imaging studies. And I want to confess that I came to be a researcher of attention deficit hyperactivity disorder, what I call the back door, because my interest has always been on understanding the effects of drugs, of abuse in the human brain, and why is it that they produce addiction, and what happens in the brain of people that are addicted that leads them to the loss of control. And at the same time, another area of interest has been what are the factors that increase the vulnerability for an individual to become addicted to drugs. And through that research, I came across the fact that there is a tremendous overlap between the neurobiology of attention deficit hyperactivity disorder and some of the neurobiology that you observe in substance use disorders, and there's clearly overlap in terms of the pharmacology of some of the most frequently used treatments for ADHD and some of the most addictive of the drugs of abuse. So trying to inquire that seeming paradox between two diseases that appear so different and drugs that are therapeutic on the one hand but highly addictive on the other, trying to understand that these two phenomena can exist and why they exist it's a strategy to understand neurobiology. Now, we know that attention deficit hyperactivity disorder is a very, very frequent psychiatric disease, and in fact, it is believed that it is the most frequently recognized psychiatric disorder of childhood and adolescence, and it is also a disease that it is increasingly being recognized in adults. Until relatively recently, it was believed that most individuals that had ADHD will overcome their symptoms once they reach adulthood. Now it's recognized that unfortunately that is not the case, and that probably most of the cases with ADHD will continue to develop symptoms, will continue with symptoms in adulthood, though the symptomatology changes. Whereas in childhood and adolescence, for example, there is a strong predominance of hyperactivity along with inattention. As that individual transitions into adulthood, you tend to see a decrease in the hyperactivity and a predominance of the inattention. Also, another factor that is now recognized is that while in childhood and adolescence, the prevalence of ADHD is much higher among boys than girls, that does not seem to be the case in adults, where the prevalence of ADHD is equivalent in males and females. What are the numbers of cases in the United States of ADHD among individuals that are between 4 and 18 years of age? The numbers vary depending on what survey you look at, but they are very, very high. And for example, the American Psychiatric Association estimates between 3 and 7%. On the other hand, the CDC, on a recent report, basically reported a prevalence rate of 9.4% among individuals 4 to 18 years of age. So it's a very, very high rate. And the differences that are obtained between the classical diagnosis as may be done through the DSM and the population-based diagnosis may reflect severity of the presentation. We have very good treatments for attention deficit hyperactivity disorder. Again, there's a lot of controversy in terms of how valuable they are long-term. But what it is recognized is that stimulant medications are very good at handling the symptomatology and improving many of the behaviors in individuals with ADHD. Initially, most of these treatments were given for children and adolescents, and this is actually the rate, the prescription in millions for different ages in the United States as a function of age group throughout from 2002 and 2010. And for two of the most frequently used drugs, amphetamine and methylphenidate. And I'm showing it to you to just actually recognize something that we have been seeing now for close to 20 years, that there is a continual increase in the number of prescription of stimulant medications in our country. And you see that for amphetamine, and you see that for methylphenidate. But what we're also seeing is that the increases are most dramatic among the adults. And that reflects in some way the recognition that attention deficit hyperactivity disorder is not, as it was believed in the past, a disease that one would overcome during adulthood. I also find it very interesting, and this is something that has caught the attention more recently, but nobody really has studied it, and I'm presenting it to you. This is data that has not been published. It's actually extracted out of the Verispan database, which provides the number of prescriptions that are given by pharmacies. And what you see in this data set immediately is that whereas methylphenidate may be the most frequently used drug among children, and to a certain extent adolescents, that is not the case for adults in whom amphetamine appears to be the favored medication. And you can see that across different surveys. Whereas on the other hand, methylphenidate you don't see any increases in adulthood, it's just basically stable. That is not the case of what we're observing with amphetamine. I must say that in these numbers, one of the concerns that always emerges, because we've seen the fourfold increases in the number of prescriptions within periods that are very, very short. The question is there fourfold increases in ADHD cases? Is there fourfold increases in recognition of the disease? Or is some of this medication, in fact, reflects diversion of stimulant drugs by people that don't have ADHD, that are using them in order to improve performance? And that is one of the recognized problems about the use of stimulant drugs, a problem that emerges not just among young individuals, but that is observed across individuals of all ages. It's very much paid a lot of attention among adolescents and young adults because they use it in order to prepare for exams. So through the use of the stimulants, they actually can study without having to fall asleep. And this is an area of big controversy in terms of to what extent it's really a cognitive enhancer, to what extent this could be harmful. But let's come back to the stimulant medications and their use for ADHD. And this is the paradox that I was referring to. On the one hand, we have what is considered as the most addictive of all of the drugs of abuse, methamphetamine. And the addictive properties of drugs are recognized to reflect the fact that they have the ability to increase dopamine in the brain, particularly in reward areas of the brain. And methamphetamine, of all of the drugs of abuse, is the one that is most potent at increasing dopamine. And thus, it's not surprising that methamphetamine is the drug that produces addiction much faster within a very short period of administration. And by the way, for those that are not familiar with the terminology of addiction, addiction is a condition that results in people that are vulnerable from repeated drug use that leads to the compulsive intake of the drug and the loss of self-control that perpetuates the use of the drug, even though the individual may no longer want to take it. And that's what characterizes addiction. Well, repeated use of methamphetamine is the one that produces faster transition into that state of addiction. Cocaine also is one of the most addictive drugs of abuse. Well, these two drugs, methamphetamine is very similar pharmacologically and even in its chemical structure to amphetamine. And amphetamine, as I mentioned to you, is, along with methylphenidate, that most frequently prescribed medication for ADHD. And in fact, both methylphenidate and amphetamine are the most frequently prescribed psychoactive drugs to children and adolescents in our country. And these two drugs are very similar. On the other hand, cocaine and methylphenidate, though they are not chemically similar, pharmacologically are almost identical in terms of their ability to modify the transporters, which are the targets for cocaine and the targets for methylphenidate. And this, to me as a researcher, has been one of the areas of greatest interest to understand why a drug such as, by the way, methamphetamine used to be used in this country for many years for the treatment of attention deficit hyperactivity disorder. Amphetamine, which is widely used in the United States, is one of the most problematic drugs of abuse in many places in the world, including Japan. So there have been severe epidemics of amphetamine abuse in countries. So this is a very addictive drug. So is methamphetamine, yet methamphetamine can be therapeutically beneficial, as was shown in the past for ADHD, and so is amphetamine. Here we have methylphenidate can also be addictive, and there's been cases of people becoming severely addictive to this drug. Cocaine is highly addictive, yet methylphenidate is used and is very beneficial in the treatment of ADHD. More recently, there's been another drug that shows efficacy for treatment of inattention in ADHD, and that's modafinil or Provigil. This is a medication that was not approved by the FDA because of its dermatological side effects. But like these other medications, it shares the common effect of increasing dopamine in the brain. And all of these drugs of abuse, in their addictive properties, the reason why they are addictive is they are increasing dopamine in the brain. So when you have a situation where all of the therapeutic drugs of ADHD, the main ones, the most potent ones, increase dopamine, and all of the drugs of abuse, in order to be addictive and rewarding, have to increase dopamine, then you actually ask the question, well, where is the overlap? What does it tell us about the neurobiology of ADHD on the one hand, and of the abusing properties of these stimulant drugs? Well, to start with, it is important to recognize that dopamine, which is a neurotransmitter, is a crucial neurotransmitter for survival, because it is the system that modulates the reactivity of areas of the brain involved with reward. And reward is the mechanism by which nature incentivizes us to do behaviors. So, for example, dopamine is implicated with a sense of well-being. And the rewarding effects of food are related to the activation by dopamine of these pleasure centers. And it is the activation of dopamine of these pleasure centers that in turn sets the motivation to procure and consume that food. So in animal models, for example, where you can generate these little mice that don't synthesize dopamine, these animals die of starvation. And they die of starvation because they don't have the motivation to consume the food. So in order to make these animals not die, you have to deliver the food into their mouth. And it is not because they cannot move. It's the lack of motivation to engender the behaviors that are necessary in order to procure the food. So it's as important as that. It is very important in movement. And one of the most well understood diseases in the brain, neurodegenerative diseases, is Parkinson's disease, in which you have a damage of dopamine cells that leads to the inability to initiate movement. It's also extremely important with attention. And indeed, the ability to sustain attention requires dopaminergic pathways. And without dopamine pathways, it is very difficult to maintain the attention on a task. And finally, as I mentioned, the reason why drugs are abused is because they are actually activating these dopamine reward systems in more potent ways than food, and in that process trigger adaptations that ultimately result in addiction. As you may imagine, from the diversity of the roles and the involvement of dopamine, the effects of dopamine are actually multiple, and it ultimately, depending on which area it regulates, you're going to have a predominance of an effect of dopamine on a particular function. For example, in the nucleus accumbens, which is one of the central pleasure centers in the brain, dopamine in this center is involved in reward and motivation. And so in an animal, if you destroy the nucleus accumbens, or if you damage the pathways that from the dopamine cells, so the dopamine cells are actually a very few, it's 10,000 cells on each side of the brain, dopamine cells in the deep parts of the brain that send projections, that is sort of touch different areas. One of them is the accumbens. So this projection is involved with reward. And if you damage it, those animals are no longer sensitive to reward. And unfortunately, that is associated with a loss in motivation and drive. But these dopamine cells also touch into other parts of the striatum, like the caudate. And the caudate is implicated in cognitive operations, including attention. It also sends projections into the prefrontal cortex. And this projection is indispensable for the proper function of the frontal cortex, which is actually crucial for us to exert self-control and to exert judgment and to actually be able to keep in our brains multiple pieces of information that are indispensable for us to perform cognitive tasks. So the dopamine system, so when you give a stimulant drug or when a person takes a drug of abuse, you are going to be stimulating, in most cases, more than just the dopamine nucleus accumbens, that center of reward. You're going to be affecting the prefrontal cortex. You're going to be affecting caudate. And now we know that indeed the ability of stimulant medications to be beneficial for the treatment of ADHD in part relates to dopamine modulation of the prefrontal cortex, but also now we know it also relates to its modulation of the striatal regions. And these are just the projections of all of these areas of the brain. Now, when using imaging, how do we study directly the ability of these drugs or medications to increase dopamine? The way we do it is actually with a technology that is named as positron emission tomography, because it actually measures the concentration of positron emitters. It's a nuclear medicine device that allows you to locate and measure the concentration in a tissue, in this case the brain, of radioactive substances, radioactive compounds that are labeled with positron emitters. And I'm not going to go into the details of positron emitters, just to say that they have a very short half-life. The one that is most frequently utilized, carbon-11, has a half-life of 20 minutes. And the beauty of that is that by having such a short half-life, it's a safe radioactive compound. So it can be used with minimal invasiveness for the individual. It's a safe procedure. The other thing is that you have carbon-11, which is an element of life, and that gives you tremendous flexibility because you can label compounds with changing what carbon, with a carbon-11, and study them interacting in the human brain. So how do we measure changes in dopamine with this technology? The way we do it is we use a compound, in this case the compound name is raclopride, that binds to dopamine receptors that are empty, that are not occupied by dopamine. Most of the time, when you're not taking a drug or you're not being strongly stimulated, most of these receptors are empty. Approximately 90% of those receptors are empty. So when you give your radioactive raclopride, it binds to these receptors. You can measure it with a PET imaging device, and you can quantify the concentration. These receptors are predominantly located in the central parts of the brain, and you get this signal. The red represents the very high concentration, so it's color scaled. And then you can bring the subject back, and in this case, we're giving them methylphenidate, Ritalin, which is, as I say, one of the two most frequently used medications for treatment of ADHD. Methylphenidate acts by blocking the dopamine transporter. So this is the dopamine cell, and the dopamine cell liberates dopamine, and that dopamine has a very limited time to interact with a receptor because it is immediately recycled back into the terminal, back into the cell through this transporter. And that is the function of the transporter, that once dopamine is released, to recycle it back and terminate the effect of dopamine in this synapse. And by doing that, the effect of dopamine is very limited. But when you give a drug like methylphenidate, what it does is it blocks this transporter, so that dopamine cannot be taken back into the terminal, and it stays there for a much longer period of time, enabling it to bind to the receptors, not just at higher quantities, but also to bind there for a much longer period of time. So that when you do your raclopride, dopamine has accumulated because methylphenidate is blocking the transporter, is occupying those receptors, and raclopride cannot bind. So when you do your imaging, long and behold, you see that decreases in the radioactivity because dopamine is competing directly with the raclopride. And when you do mathematical modeling and you compare the binding when you are not giving the drug versus when you are giving the drug, you can actually quantify the changes in dopamine produced by this medication, methylphenidate, or drug if you actually inject it instead of giving it orally. In this particular study, we were interested on understanding the rewarding effects of methylphenidate. When someone takes methylphenidate orally therapeutically, they may not even feel it. They certainly don't report it as euphorigenic. But if you take that same drug and you inject it, that drug can be highly, highly rewarding. And cocaine abusers, in fact, do not distinguish it from intravenous cocaine. And in animal models, primates or rodents cannot distinguish intravenous methylphenidate from intravenous cocaine. Long and behold, just like methylphenidate, intravenous cocaine blocks the transporter with a similar affinity. And it increases dopamine, and that is associated with rewarding effects. Similarly, in this case, when you inject intravenous methylphenidate and you monitor the changes in dopamine, you can see exactly the same thing. The larger the changes in dopamine produced by this drug, the more intense the high, indicating that just like cocaine, just like nicotine, just like marijuana, the same thing has been shown for marijuana, the larger the changes in dopamine, the more intense the high. And by the way, the same thing is true for methamphetamine. So then the question is, what's going on? If on the one hand we have a medication that increases dopamine and that is associated with a high, is it not dangerous to give it to children and adolescents with ADHD, which we know already are at higher risk of abusing substances? Well, one of the big, large differences in the paradigm pertains to when you're dealing with a drug is the route of administration. And we know that from the studies in substance abuse that the speed at which a drug gets into the brain is crucial for its rewarding effects. And this explains why the routes of administration that are associated with a higher risk for addiction are injecting and smoking. Why? Because these two routes of administration leads to the fastest entry of the drug in the brain. And in turn, that is crucial for the drug to have rewarding effects. And when we give methylphenidate or Ritalin to treat ADHD, we give it orally. And for many years, actually, it was believed by many clinicians that one should not worry about oral methylphenidate as a stimulant drug because it was believed it's metabolized very rapidly. It has very low stimulant properties. In fact, it was postulated that it will not increase dopamine, but instead may decrease it by activating inhibitory autoreceptors. So we went ahead and used this technology to try to address that question. Is it correct that oral methylphenidate, Ritalin, at the doses that are used clinically, is a weak stimulant drug, that it does not increase dopamine, and that's therefore the reason why when people take it orally, they don't feel high? And we did a study and we found that it was absolutely incorrect, that indeed oral methylphenidate at a dose that is clinically relevant, these are adult subjects, so it's approximately 0.75 grams per kilogram in this case. You see the significant decrease in the radioactivity when you give this drug because dopamine is going up. And this is the model parameter that we're using to quantify changes in dopamine. And you can see, just like one was observing in the intravenous methylphenidate that was associated with a high, a similar magnitude in the changes in dopamine assessed with this particular method. On the other hand, when you look at the self-reports of high, you see that basically, except for these subjects, none of these subjects reported any effects that were different from placebo. So then the paradigm is, what is going on? Why is it that in this case, the changes in dopamine are associated with a high, whereas in these ones, in this same brain region, they are not? And the answer relies exactly on the rate at which the drug is getting into the brain. These measurements were done 1 hour after administration of oral methylphenidate, which is actually when you start to see the peak therapeutic effects. These ones were observed 1 minute after its administration. And when you actually use PET studies to directly label methylphenidate with carbon 11 and monitoring the time it takes to get into the striatum, so this is directly monitoring how long it takes for Ritalin to get into the brain when you give it intravenously versus when you give it orally, you can see the striking difference. When you are giving methylphenidate intravenously, the drug gets into the brain within 5 minutes. When you are giving the drug orally, the drug does not peak until 60 minutes after its administration. And this, in turn, leads to a very different signaling within the brain. Very fast changes are associated with reward. On the other hand, these long-lasting changes in dopaminergic are associating with activities that are related to sustained attention. And this is actually one of the reasons why the same drug can be, on the one hand, therapeutically beneficial and improve attention, sustainability of attention, and on the other hand, when injected and administered in a route that leads to very fast concentrations, can be highly addictive. So knowing that these stimulant medications that are the most potent in the treatment of ADHD are beneficial, does that mean, and they all increase dopamine, that they may be beneficial because there is a deficit in dopaminergic pathways in this disorder? And that is, of course, a simple question that follows a simple reasoning. But in my brain, it's always very good to go for the most obvious first question, and if that is not correct, then you can become much more convoluted on your questions. But if stimulants increase dopamine and they are beneficial, then could it be that they are beneficial because these kids or these adults with ADHD have a deficit in dopamine signaling, and thus amplifying those signals with these stimulant medications is beneficial? So we have been, along with my colleagues, and I have colleagues from multiple universities, including University of California, Irvine, have been studying the dopaminergic pathways in adults with ADHD. We have not studied children with ADHD because of most of our studies up to now have been using positron emission tomography that requires radioactivity. And the use of radioactivity in individuals that are less than 18 years of age is actually associated with greater risks than it is in an adult, and that's why we don't study it in children or adolescents. But we are studying adults that started with ADHD before age 7, who had never been medicated. So these are individuals that have had ADHD all of their lives, but have never been medicated. And we've studied different aspects of dopamine signaling. One of the first one that intrigued us is if stimulants increase dopamine, are there deficits in dopamine release in these individuals? So we asked that same question using that same paradigm that I've just showed you, comparing the ability of methylphenidate, which blocks the dopamine transporters, and it increases dopamine just by blocking these dopamine transporters, between ADHD adults and normal controls. Now, I'm going to just mention one thing that is very intriguing about methylphenidate, and this pertains to methylphenidate. Methylphenidate blocks the transporters, so dopamine accumulates because dopamine is being released, but it's not recycled back. But the magnitude of this increase is going to be a function of two things. You probably are guessing it. One of them is blockade, but the other one is the amount of dopamine that is being released. And we know both from animal and human studies that there is significant variability in dopamine cell activity and release. So one of the questions that one of the hypotheses that we have is that in ADHD, there is a deficit in dopamine cell activity that results in a decrease in dopamine release. So by using this paradigm where we block the transporters, we wanted to actually quantify the magnitude of the increases in dopamine, which could be, in a way, when we control for transporter blockade, a way of assessing dopamine release in these individuals. And when we did these studies, what we found was, indeed, that this is the average images for the controls when you give them the placebo, and this is the average images when you give them the methylphenidate, and you can clearly see the decreases in the binding. This is the ADHD subjects, and you can, by just visually comparing these two images, you can see that this effect is markedly attenuated in subjects with ADHD. And when you quantify it in the striatal regions, what we observed was that this effect appears to be predominantly in the caudate areas of the striatum. And the caudate is different from the putamen. The putamen is more implicated in motor control. The caudate, on the other hand, is more implicated in cognitive operations such as sustaining of attention. And in Parkinson's disease, for example, and I told you that Parkinson's disease is the disease where you damage the dopamine cells, that the predominant effects are observed more in the putamen than in the caudate, which explains why in Parkinson's disease you have a predominance of motor dysfunction as opposed to that of cognition. Well, on ADHD, we're seeing consistently across a wide variety of experiments that the caudate is much more disrupted than the putamen. And again, I'm emphasizing these are adults. So I assume and extrapolate that perhaps something similar is going on in adolescents, but we really cannot necessarily imply that it is identical. And we also showed that the magnitude of those changes in dopamine was directly associated with the symptoms of inattention. That is to say, those individuals in whom methylphenidate did not increase dopamine. So there are subjects in whom you give this drug and dopamine does not go up. And those individuals are the ones that have the most severe symptoms of inattention. So in our hands and in our studies, and actually now we recently replicated this, but with a therapeutic hand to it, that this decrease in dopamine in the caudate is associated with symptoms of inattention. And the ability of stimulant drugs to increase dopamine in the caudate is associated with improvement of symptoms. Now, why? So we're measuring dopamine here in the caudate, in the putamen, and with the newer instrument that we have with higher resolution, we can now start to look at it in the accumbens. So the deficits in dopamine here that we're seeing here, what do they mean? Do they mean, as I basically say, that this is disrupted, that the dopamine cells are not functioning and thus they are not releasing dopamine? Whether it is in the caudate, in the accumen, or even in the putamen? Or is it the other way around, that the frontal cortex, actually which regulates the dopamine cells, is abnormal? And at this point, there is evidence that in some instances, the pathology of ADHD may emerge by damage to dopamine cells. And in others, there is evidence that it's consistent more with damage of the prefrontal cortex. Well, our strategy has been, in order to try to determine is there a predominant deficit of the dopamine cells or not, is to evaluate in subjects with ADHD adults two important markers of the communications of what we call the dopamine synapse. One that serves us to actually identify the marker of the dopamine cells, the dopamine transporter, because it is located in the dopamine neuron. And the other, the dopamine receptors, because they are predominantly, our signals with PET are predominantly located on the cells which with the dopamine cell communicates. So in the brain, cells basically are networks, so they have these connections. So one cell sends a chemical message, and it's the way it communicates with the other. So the receptors are used as the markers of the cells which dopamine is communicating. And we've used it to actually determine if these markers, the transporters as a marker of the dopamine cells, and the receptors as a marker of the cells with which it communicates, are abnormal in individuals with ADHD, again, that have never been treated and who are adults. So in a large cohort that we've actually carried, it took us approximately 5 years to complete this study because of the exclusion criteria. We also were excluding individuals that have comorbid psychiatric diseases, because that's another issue with ADHD. It is frequently comorbid with conduct disorder. It is frequently comorbid with depression. It's frequently comorbid with substance use disorders. So we studied a group of 44 controls and 53 ADHD subjects and asked the questions, are there deficits or changes in transporters? Are there deficits or changes in dopamine D2 receptors? And our findings actually was quite unexpected, and it's summarized here. This is the anatomy. These are the areas of the brain where we actually quantify the receptors and the transporters. And what you are seeing here is a parametric result that identifies within the analysis of the whole brain where the dopamine receptors and the dopamine transporters differ between controls and ADHD subjects. And the differences were towards a decrease both on receptors and on transporters on ADHD subjects were compared with controls. And what was fascinating to me, and it was a surprise because actually I did not predict it a priori, was that the abnormalities were seen both in receptors and transporters. So it's not just the function that the dopamine cells are dysfunctioning, but also that the main pathology in these markers was on the ventral striatum. It was ventral caudate and nucleus accumbens. And those are classic reward areas of the brain. So, which again was unexpected, because overall we describe attention deficit disorder as a disorder of attention implicating more the cognitive prefrontal and dorsal caudate parts of this system. So if you have a deficit in the reward sequence, then it follows that is there a deficit in reward, reinforcement, and motivation in ADHD individuals, which you would predict based on these findings. And is that how important is it? Well, if you look at the literature of ADHD, investigators now for many years have described the fact that individuals with ADHD are less sensitive to reinforcement. And that indeed there have been hypotheses that there are two pathways that can be dissected in ADHD. A ventral pathway in the dopamine system, the one involved with reward, and a dorsal pathway, that one involved with attention. And our findings clearly are implicating this reward motivation system as one of the most fundamentally abnormal in adults with ADHD. And moreover, this pathway, these abnormalities in our studies were not just related to inattention, which is interesting, but they were also related to motivation. The lower the markers of dopamine transporters in the nucleus accumbens, the lower the markers of dopamine D2 receptors in the nucleus accumbens, the lower the scores in motivation. So indeed, in ADHD, the deficits in dopamine in the reward pathways are associated with motivation. And in my brain, this has always been a very intriguing phenomenon. And I'm going to confess a story. It's true. I'm not going to give you the details because I'm very embarrassed about it. But I was in a meeting, this was several years ago, I was sitting there in a meeting of ADHD, and they were presenting data on ADHD, and I was bored of my mind. I could not pay attention. I was horribly bored. And I was saying to myself, Nora, pay attention, this is ADHD. And then it hit me. It was horribly boring lecture. Then it hit me. I cannot pay attention because this is terribly boring. And yet, I know I've learned this. When I go to these meetings, and you have to realize that I have to go to very many meetings, many of them are horribly boring, but I need to pay attention. So what do? I drink coffee. And coffee makes me sustain attention no matter how boring. It's no longer boring. So that hit me. So enhancing dopaminergic signaling may have the ability to enhance the saliency of the task. And that's exactly what dopamine does. When dopamine systems are activated in the brain, that is processed as salient, as rewarding, as reinforcing, as motivating. So could it be that one of the therapeutic benefits of the stimulant medications that activate this dopamine reward system is to enhance the saliency of the task, enabling it by making it more interesting to kids to pay attention and to improve performance. So indeed, in this case, as you sort of see, the low function of these markers is linked with poor motivation, and I'm not showing you the data, but it's also linked with inattention. And motivation and inattention are also highly correlated. Individuals that have very low scores in motivation are the ones that are most inattentive. So then we asked that question, and I was for many years telling my colleagues on the ADHD, those working with children on ADHD, well, have you asked the children when you give them the stimulants if their tasks are more interesting? No, I haven't. Well, why don't you do it? And I could not get a single one of my colleagues to do it. So very frustrated, I said, okay, I'm going to do it. So I did a study, but I'm actually an imager person, so I did it in adults, so this is not in children. And I took adults, and I put them doing an arithmetical tasks. And the task was basically, the difficulty of the task was basically adjusted so that each individual would correctly answer 80% of the questions. And I did them, I presented them under two conditions, and one of them I gave them methylphenidate, another one I did not. And I measured changes in dopamine, and I measured I asked them how exciting, how interesting it was. And these are the results. So here is the scores, the self-reports of interesting, exciting, motivating, tiring, boring, when they actually had the placebo in blue versus when they have the methylphenidate in green. And when they were on methylphenidate, basically, they significantly increased the self-reports of interesting, exciting, motivating. All of them were significant. This you see a trend effect. It was not significant because the task itself was not reported as boring. So we really didn't have much to work with. I predict if it had been very boring, you would have seen a difference. But certainly our hypothesis was corroborated. Methylphenidate makes things much more exciting and interesting. And the magnitude of those effects was directly linked with the ability of methylphenidate to increase dopamine. So in those subjects in whom methylphenidate increased dopamine the most were the ones that showed the highest increase in motivation when they were performing the task, indicating indeed that stimulant medications, whether it is a child, an adolescent, or an adult, may be therapeutically beneficial because they're actually making the task much more exciting and interesting. Now, what are the implications of these findings? Well, there are many implications, but I want to basically, to start with, address them with respect to the therapy. We have all, and those of you that have dealt with children with ADHD, I'm sure that you have had parents come to you and I said, I really don't think that my kid has a problem. Because they can still sit for hours in front of the video, sustaining the attention for hours. And yet they cannot perform a simple mathematical task for more than 5 minutes. Well, what is the difference? The difference is that that video is inherently salient, whereas this task is terribly boring. So an inherently salient stimuli, because that's the way that our brain responds, activates dopamine cells. So the challenge is, why not provide an educational intervention that is inherently salient in order to improve performance. And in fact, we do that to a certain extent. A grade is a reward. If I get a 10, that's a reward, and that makes the task much more salient. And in our studies, actually, one of the things that I hire a postdoc, this is also true, but sometimes my brain is a little bit wild. I hire a postdoc, and this was short after I was doing these studies, and certainly in our studies, we use money as a reinforcer, very potent reinforcer. And I sort of said to her, Rita Goldstein, now she's a scientist, I said to her, can you show to me that you can increase the inherent value of money with a stimulant drug? Because you should. And it's until now that they are doing the study, so they are seeing the activation of the reward system to money, and you can actually increase the activation by giving them a stimulant drug without having to increase the amount of money. So that just clarifies how important the dopamine system is. But it highlights the notion of educational strategies for children that are much more salient, incentivizing them and improving performance. That's one of the issues. The other issue that is very relevant too is the implications of this finding with respect to substance use disorders. There's been a lot of concern because these stimulant drugs can be diverted and can produce addiction. But when they are diverted, they usually are snorted or injected. Nonetheless, that issue has always been a consideration. The problem is, though, that if you have a kid that has ADHD and is not properly treated, or an adult with ADHD that is not properly treated, they are at increased risk of using stimulant drugs to auto-medicate. And that has been reported in the literature, for example, for cocaine abusers in whom an undetected ADHD led them to take the drug. And in those cases, if you treat them properly, basically cocaine-taking behavior disappears. But you have to do an intervention before the addiction has developed. So the importance of something like this is that the proper diagnosis of someone with ADHD in order to implement a stimulant drug. A question that a lot of people ask me as a researcher and ask me as a director of the National Institute on Drug Abuse is the concept of if you're giving a stimulant medication, and we know that drugs, one of the things that they do by increasing dopamine is trigger neuroplastic changes associated with learning and memory that can result in addiction. The question that I always get, certainly from parents, is, will it make my kids more vulnerable to drugs later on in adult life? And this is a question that a lot of investigators have tried to answer. Where does it stand? Right now it stands that in adolescence, proper treatment of children with ADHD decreases experimentation. In adulthood, it does not seem to have that protective effect. So if you treated adolescents with ADHD with stimulant medications and you follow them in adulthood, there does not seem to be that protective effect as of the data that we currently have. And thus highlighting the importance of actually not just relying on a medication intervention, but also in parallel providing the educational behavioral interventions that will facilitate the transition of that individual from a medication period to one where they can achieve and perform properly without necessarily having to be maintained on stimulant medications for the rest of their lives. So this is my summary. So my summary, it is deficit in dopamine neurotransmission in ADHD. There are deficits in dopamine neurotransmission. And in the nucleus accumbens is where we're seeing the most prominent deficit, as well as in the ventral caudates, which are crucial regions in reward and motivation, provide evidence, in my view, of a motivation deficit in ADHD. And those of you that know me, sometimes actually sort of my boldness of my brain sort of says, we should rename it and sort of call it attention and motivation deficit disorder. That's what I would propose based on what the data is showing. This finding is also relevant because this deficit may also be the reason why kids with ADHD are at much greater risk of substance use disorders. because they may be taking drugs in order to compensate for that deficit. And finally, stimulant medications, methylphenidate, amphetamine, modafinil, which acutely increase extracellular dopamine in the brain, enhance interest and motivation for the task, and that in turn improve performance, which may be one of the mechanisms by which they are therapeutically beneficial. It is not the only one, and if you ask me questions, I can display other mechanisms by which we know stimulant medications are also beneficial. And my last slides are my colleagues at Brookhaven National Laboratory, with whom, of course, this work would have not been possible. And I always thank the National Institute of Drug Abuse for its generosity and support. Thanks very much for your attention.
My main thing is, you said something about the appropriateness of the dosing of Ritalin or Adderall. You have to make sure that it's appropriate before they start abusing it and stuff like that. What I was thinking is it possible physiologically, the degree of dopamine, the more there is in the body, the more you get addiction. I mean, if you just keep it to the minimum secretion in the body, like with the low dose of Ritalin or so, that you'll get the benefit, you'll get all the therapeutic effect. When you go higher up, which sometimes doctors cannot control it and physicians start taking too much, when you have higher level of dopamine in the system, that's what it triggers the what do you call it, the reward system, and then you start abusing. So I was just thinking, I'm not a scientist, but I'm just thinking that.
And you're absolutely correct. And I said what I said is when you take it orally, and I should have been explicit and saying at the doses used, at the doses prescribed, which in the low range, number one, and within the conditions at which it's administered. So when you give an oral methylphenidate, 20 milligrams, you give it for that child to use within the schoolwork. When you, and one of the things, and again, I don't have time to go into this, but it's something that I always fascinated. The effects of methylphenidate and amphetamine are dependent on the context at which you give them. So kids take these tablets orally when they go to a discotheque and they get high. Why? Because the dopamine cells starts to get activated in a salient environment and they release more dopamine. So you magnify the effect. Whereas on the school, the effects is much less. And that has been described. For example, the first time that it was described was when they were comparing the effects of methylphenidate. Children, they were giving in the morning, they saw them in the schoolwork versus in the playground. And you would not be able necessarily to see the effects on the playground, whereas in the school were very, very strong. So that's one. The other thing, oral tablets, when they are abused, they're also combined with other things like alcohol and nicotine. Nicotine, cigarette smoking, increases dopamine cell firing. So you're increasing dopamine cell firing and you're blocking the transporter, which is the way that you recycle dopamine. So you're amplifying this effect. So when I said it, I should have explicitly said it, when taken at the low doses prescribed therapeutically, but you are very correct. There are people that give 1 gram a day. But at the regular doses, within the context of the schoolwork, it's not rewarding. For most people, even in my experiment, you see one of them did. But overall, it's not. Now, with respect to your question, is there therefore perhaps a greater risk for addictiveness of stimulant medications? And by the way, it is also recognized that most kids, when they are given, that have ADHD, when they are given their medication, do not even like the way that it makes them feel. Some of them become dysphoric, you can hear them tearing. They take it because they see the improvement in performance. Now, some of them, a very small percentage, and there are cases that have been documented in the literature, can become addicted to their medication. So we should not become all safe and says there's not going to be a case. There are cases of individuals that were properly prescribed that become addicted. It's very rare, but it does happen. So is there an association between the doses and the addictiveness? I would say, I would predict that there is. that the higher the doses, the more potent you get, the greater the likelihood that you will trigger the neuroplastic changes. And I said it with methamphetamine. Methamphetamine is the drug that produces the addiction process the faster. Why? Because it increases dopamine the most. So, and the amount of dopamine is going to be a function of what the doses that you're giving. So that's why I would predict that it would be the case.
My question is with regard to some of the developmental and diagnostic implications of your work. Since you're working principally with adults, and as you described, the phenotypic portrayal of ADHD changes developmentally, that you no longer have the issues of hyperactivity and impulsivity, could it be that you are studying specifically the inattention component of ADHD, and that's why you're not bringing in the prefrontal systems and issues of executive function control?
Well, one of the things, and in our sample, in fact, it is, and I'm glad you're bringing it up, because the symptoms of hyperactivity are much lower, and in no case have we seen an association between the dopamine measures and hyperactivity, but I think that because we don't have the range of values, they're very low. However, investigators in Europe, in Denmark, the group in Denmark, Albert Getty and his group, has been doing similar studies in children and adolescents with ADHD. And in their case, they're actually documenting an association between these changes in dopamine and hyperactivity. So I wouldn't rule it out. Now, we are focusing in dopamine, but stimulant medications also increase noradrenergic function. Methylphenidate is a blocker of norepinephrine transport. Modafinil also blocks the norepinephrine transporter. Amphetamine releases noradrenaline. So I don't rule out the possibility that the hyperactivity component may have a stronger element of noradrenergic dysfunction. We cannot rule it out. What I can tell you is that there is a strong component of dopamine in the syndrome of inattention. Clear cut.
Hi, I wanted to ask you if you feel that Adderall is a good medication for an 8-year-old boy with attention deficit disorder, hyperactivity?
Well, I mean, there is a vast number of studies having shown that Adderall and Ritalin, both of them are very effective medications that can improve significantly outcomes in children and adolescents with ADHD. However, without knowing the details, it's very difficult for me to know whether it is appropriate or not, because what is also reported is that there is a significant number of kids that are being misdiagnosed with ADHD and are receiving stimulant medication that in fact don't have ADHD. So that is why, I mean, and that is recognized in the field, that there is sometimes pressure, actually from the school systems, where parents are told either you put them on a stimulant or he goes out of the school. That type of pressure sometimes results in kids being improperly medicated with stimulant medication. So I wouldn't be able to say.
Some parents have come to me and wanted to have their children take a break from stimulants over the summer. And I can't tell from what you said whether that's a good idea or what should I say to those people.
And again, I think that it is important to take each case on its own basis. Because there may be kids that if you do that summer vacation, their behavior deteriorates so badly that you don't gain anything. However, aside of those kids, my recommendation is to do a vacation on the summer. And the reason why, actually, it has to do with, well, two things. One of them is it has been shown, contrary to what it was believed for many years, that treatment of children with stimulant medication reduces their growth. And in the past, it was believed that there was catch-up. Now the data that has followed these kids prospectively shows that there does not appear to be a catch-up. But on the other hand, the opportunity of giving these vacations, it's believed, may interfere with those growth effects of the stimulant drug. That's one of them. The other thing, and this is something that we found, that we've actually, it's impressive, it hasn't yet been published, and it's in adults. But we've seen that when you treat someone repeatedly for 12 months continuously with this methylphenidate, you become tolerant to its effects.
To become what?
Tolerant. So the ability of the drug to increase dopamine goes down. So I would play with that period. I don't think that it's irreversible. So by stopping it, you may be able to reverse that tolerance. So that's the two reasons why I would tend to favor the use of discontinuing stimulant medications during the summer. But again, I emphasize it has to be addressed on an individual basis, because I've seen patients that deteriorate so badly that then they cannot even play with others, and in those cases you have to wait.
Hi. If a child's been diagnosed with ADHD and you've tried all of the different stimulant medications and they have not had a favorable response at all, do you think that that warrants questioning the diagnosis of ADHD?
Well, I think that, first of all, on the one hand, one needs to study and make a correct diagnosis. What I can tell you is that a normal child that is inattentive and in a very boring class, the more boring it is, you give them a stimulant, they're going to improve. So the fact that this child or adolescent is not improving makes me, I would like to evaluate and learn better what is exactly where the symptomatology, because it is correct. That's sort of the more the boring, and indeed in studies where they are actually, because I tell you, people are diverting these drugs in order to help them study or prepare or for exams. And then there was a professor in Harvard that admitted the need to use stimulant in order to write his or her book. It was a kid. So they are being, and the issue is that when you're studying something, so the investigators say, does it improve cognitive performance or not? It improves cognitive performance in normal people when you're doing something very boring and repetitive. It interferes with cognitive performance when you are doing something very creative. That requires flexibility.
A bunch of us in here study autism and other disorders and are fond of saying that ADHD, or symptoms of inattention and hyperactivity, are comorbid with a lot of the disorders we study. Do you have any reflections on the neurobiology of ADHD when it's comorbid? Is there such a thing as an ADHD phenotype or an endophenotype that might be present in a lot of different disorders?
And it's an extremely important question. I have studied, on my experience, because I did not want to get the compound extremely clean ADHD that I realized don't reflect the majority of the cases. To start with, we are excluding substance users. But what I think that, I look at it, ADHD, like I look at addiction as diseases of circuits. And in ADHD, it appears that there is a dysfunction of a dopaminergic modulated circuit that involves the ventral striatum, the caudate, prefrontal cortical regions, orbital frontal cortex, which is where your nucleus accumbens goes into the frontal cortex. Those same regions get disrupted in other conditions. And we were discussing it before, because it's actually in terms of, for example, in addiction, there's a higher likelihood that patients that are addicted have problems of inattention. So so at what time so how do you start to dissect it? There's another area where we've been very interested, where we're also seeing, and others have seen this is actually many reports now, is in obesity. In obesity, they are at greater risk of having problems of inattention. Diabetes mellitus also is associated with a greater risk of inattention. So I would basically, it's what I state is that in all of these conditions where you have this inattention deficit, it's likely that these circuits are disrupted. What I don't know is what's driving the pathology in that circuit. Is it a primary deficit or is it a secondary deficit? And it's likely that you will have situations where this is the primary deficit, whereas in the other one, it's a downstream effect.
I have a 11-year-old boy who's diagnosed with ADHD. What is the distinction? How can I distinguish the child between ADD and that hyperactivity? Because right now I feel he's not that hyper, but for attention, he's totally, open a can, forgot that there are jackets on the floor, so that attention deficit, he's predominantly, but I don't see him hyper. So as a parent, how do I know he is? Because he functions fine and he has a social life, he's active, and he doesn't want to take his pill in the weekends.
Well, and we know now, that kids come in different shapes, forms, and varieties, and that there is a lot of diversity. And certainly, the classical one that we have is the predominantly inattentive, predominantly hyperactive, or do you have a mix? And I would put also predominantly unmotivated. But the motivation is linked with the inattention. It is not infrequent to have kids that are predominantly inattentive. It's more frequent, actually in girls you see that more frequently than in boys. In boys you tend to see more hyperactivity. But it's not uncommon, and they respond to stimulant medications. We don't really have, we have overall study, and we do this for a lot of conditions, where we have a diagnosis and we assume that all of these are homogeneous, that they are all similar. And we really have, as of now, for example, have not started to dissect differences. So are there differences between a predominantly inattentive and a predominantly hyperactive child? Another difference that I'm very interested, and if I were not director of NIDE, I would have studied this because it's obsessing me, is are there differences between those children that have ADHD and overcome the ADHD when they become adults versus those children that have ADHD and continue with symptoms into adulthood?
So this question sort of tags on the end of the last one. And that has to do with if you have, in a school situation or in a situation where you need to pay attention to what appears to be a boring external environment, and you're on stimulant medication, and you effectively learn what you're expected to learn, what is the encoding implications of that knowledge in terms of memory consolidation if you're off the drug? In other words, do you actually
absolutely.
consolidate differently? Because some of these people
Absolutely.
who've never been medicated, they probably have extraordinary competencies that are maybe very idiosyncratic. So what is learning like on and off, and what is your access to the world you learned on when you're off?
And actually that question in my brain is, I am very intrigued about that question for individuals that are studying under the effects of stimulant drugs, yes, that they may do very well on the exam, but will they remember 6 months later as well as someone that studied without a stimulant? There's no data. There's no data there. And it's one of the points that I said, because if you are studying to be a medical student and you pass your exams on the stimulants, it's a very important question. I want that person to remember it. But it's actually, and I basically, again, encourage, this is an area that needs to be investigated. And in the field of ADHD, and again, it's one of those issues that is very difficult when there is no clear-cut, strong evidence to show that there is an overall improvement on what you memorize. There is an overall sense that the performance of that kids is significantly improved in social interactions, in their staying at home. But clear-cut improvement on the ability to learn, that has been not in my view at all clearly shown. But you do improve on behaviors.
I'm a pharmacist. And so I see a parallel here between the amphetamines, including Ritalin, and the narcotic drugs, in that we have diseases, pain, which are broad spectrum of pain. You want, terrible 10 pains all the time, and 2 pains that you can just get along with, and the drugs that are used in increasing levels as you go up. Same way with ADHD. ADHD, to my understanding, is not you got it or you don't got it. It's a spectrum. And same way with the drugs that are used to treat it. You increase the drugs depending on how high on the spectrum that person is. And the abuse of these drugs is similar as well. You go beyond what is needed and you get into abuse.
You're correct. And I think that in medicine, of course, we need to make diagnosis. And, but these are dimensions, right? I mean, you have attention, and you have, on the one hand, inattention, and on the other hand, you can have people that are hyper attentive, so you have a whole dimensionality. And even within each one of us, our capacity for attention is context dependent. So if it's very boring, we're much less likely to pay attention. If we're very tired or sleep deprived, we're much less likely to pay attention. So I think that you make the diagnosis of ADHD when the inattention starts to disrupt the performance of that individual, when it becomes pathological. In a way, the same thing with pain. We all suffer pain or not, but we won't consider it as problematic or in need of medications unless it starts to interfere with our everyday activity.
Can you comment on the incidence in females versus males in childhood and adulthood, and if that's just a lack of diagnosing in young girls or something different, especially since the diagnosis requires symptoms before age 7?
Yeah, no, and I think that if I comment on that, it's going to be purely speculative. So it's speculative because there's not data scientifically. My sense that is on what's ongoing is that because in girls it's inattention, it's much less obvious and evident that there is hyperactivity. And as they grow older, and as we all grow older, the dopaminergic system functions less and less. So it's much, you see a degradation of dopamine cell activity. So if you have a deficit, it's going to become more and more apparent. So like the question that was just asked, there is a dimensionality. And even though you may have had some problems with inattention, you were able to compensate. But as you grow older, you lose that ability. So my sense is that's what's going on in women, is that that's what's happening. And that as children, they may have had some symptoms of inattention, but they were not severe enough to capture the attention or ever been diagnosed. And as they grow older, it's starting to emerge. But until the studies are done, this is, as I say, completely and purely speculative. And it would be, and I'd love to study that, but I would like to stop it. I just don't have the time to do it, but it would be interesting to compare males and females.
I'd like to ask about the uses and effectiveness of Wellbutrin for ADHD, and if you think it is effective in some cases, how it might be working?
Well, Wellbutrin, which is initially developed as an antidepressant medication, blocks the dopamine transporter just like methylphenidate does. The difference of Wellbutrin is much less potent. So for example, at the doses that you use therapeutically to treat children with ADHD, you're blocking at least 70% of the transporters. Whereas at the doses that are being used with Wellbutrin, you may be blocking 25 or 30% of the transporter. So as a dopamine transporter blocker, it's much less potent. Wellbutrin, different from methylphenidate, also has agonist properties that it stimulates acetylcholine nicotine receptors. And nicotine receptors can increase firing of dopamine cells. So it's possible that even though it's a weak blocker of the transporters, the combination of its activating dopamine cells plus the blockade of the transporters makes it therapeutically beneficial.
Dr. Volkow, I have a question on Judy Rappaport at IMH about 30 years ago did research on normal versus ADHD kids with regards to the response to stimulants. And her study basically was the tendency of making that diagnosis over the phone and somewhat casually if a child responds to stimulants must be ergo ADHD. And a report which stands the way that we took it as a tome, that stimulants improve the functionalities of all normal and ADHD. Therefore, you cannot make a diagnosis simply because somebody responds to it. Any comment to that?
Yes, and I agree totally. You cannot make a diagnosis of ADHD on the basis of the response to stimulant drugs. And as I say, you put a very, very boring task to a child, and you give them, and it's normal, and you give them methylphenidate, you improve performance if the task is very boring. You will also improve performance if you are very, very tired or sleep deprived. So, that idea but what is interesting is that a lot of people still believe that the response to stimulants is different in a child that's normal from an ADHD. And that a lot of that comes about by what appears to be paradoxical. So if you give a stimulant drug to an animal, they start to move around like crazy. It increases locomotor activity. Yet when you give a stimulant to a child that's hyperactive, moving all around, they stop. And that's what led to the belief that there was a different effect on an ADHD versus a normal control. Now we know that that's not the case. And that depending on the condition, you can generate similar responses in normal kids as those in ADHD when you give them the stimulant drug.
I have one question. Drugs of abuse can cause dopamine depletion, particularly cocaine and I think methamphetamine.
And alcohol.
And alcohol. So using therapeutic or high-end therapeutic doses of stimulants, particularly long-term in adulthood, does that increase the rate of dopamine depletion that occurs with aging? Has there been any research about that?
And we were discussing that on the way from the airport. You know, we know, and actually there's been 2 studies and with methamphetamine. Methamphetamine is very similar to amphetamine. It's very different from methylphenidate and cocaine. Cocaine and methamphetamine are different. Methylphenidate and amphetamine and stimulants are different. But amphetamine and methamphetamine, what they do is they release dopamine. So cocaine or methylphenidate, you block the transporter, and so you interfere with the recycling. Methamphetamine and amphetamine just throw dopamine out, and as a result, they throw much more than the other 2 drugs, and that's why they are more potent. In animal models, methamphetamine and amphetamine have been shown consistently to produce damage of the dopamine terminals, to damage it. And in fact, it was believed that these were, in these animal models, were used as animal models of Parkinson's disease by giving them methamphetamine or amphetamine. Now, so when the methamphetamine epidemic came around, one of the concerns that we all had, including me as a researcher, was that these individuals were putting themselves at greater risk for Parkinson's disease. But what was surprising was no one showed any evidence of Parkinsonian symptoms in methamphetamine abusers. Now, my point immediately was, yes, but these individuals are 20, 30 years of age. Wait until they reach their 50s or 60s. And the epidemic was very new. Now the epidemic is no new, and now there are 2 reported studies, and a 3rd one, which has shown this, but it's not published, showing a higher risk of Parkinson's disease in individuals that are methamphetamine abusers. Now, amphetamine, if you were abusing amphetamine at the level that it's abused in places like Japan, I would say the same risk would pertain. But when you use it therapeutically, you give much lower doses. And as of now, amphetamine has been used for more than 50 years for the treatment of ADHD. There's no evidence. My feeling is if there was an associated risk, it has been used for such a long period of time that it would have emerged. So that's why I don't think that at the doses used therapeutically, amphetamine is damaging to the dopamine cells and could increase the risk of Parkinson's disease. I don't think so. But again, we also have to recognize that most of the treatments of amphetamine was in children, and we have very little experience of using amphetamine in older adults. Now we're starting to use amphetamine in older adults. And so that may change the question, and one needs to. And that's for amphetamine. Methylphenidate in animal models, there's no evidence of toxicity no matter what. So in that respect, methylphenidate is a safer drug.
Appreciate your attendance.
The UC Davis Mind Institute was created in 1998 with a promise to find cures for neurodevelopmental disorders. Every day, our physicians and researchers come closer to fulfilling that promise. Their groundbreaking research on autism, Fragile X syndrome, chromosome 22q11.2 deletion syndrome, ADHD, and other brain disorders are helping children achieve their fullest potential. Please visit our website to find out more about current studies, upcoming events, and how you can help make a difference.